Georgian Fahey Center for Healthcare Innovation, Patient and Public Engagement Lunchtime Learning Series. This is the first one for the fall. It happens monthly, and I'm so glad that everyone could join us here in the room, but also we have people online as well, so welcome. So glad to have you guys here as well. My name is Carolyn Shimmin. I should introduce myself. My name is Carolyn Shimmin, and I work at the Georgian Fahey Center for Healthcare Innovation in Patient and Public Engagement. And today we're going to do PD 101. We're going to talk about patient engagement, kind of give you an overview of what's going on, and a little taste of things. And as we go along each month, we'll delve deeper and deeper into some of these discussions. So to start off, I'd like to make an acknowledgement that we are gathered here today on Treaty 1 land, home of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and homeland of the Métis Nation. And in coming together today, we respect the treaties that were made on these territories. We acknowledge the harms and mistakes of the past, and we also recognize the ongoing present-day colonial violence that is faced by Indigenous peoples within our healthcare system, education, justice, child welfare system as well. And we dedicate ourselves to moving forward in partnership in a spirit of reconciliation and collaboration. And also when we're talking about patient and public engagement, we need to recognize that Indigenous methodologies, research methodologies, have been doing this for a very long time, and to look at our Indigenous communities, scholars, and researchers in this area as well. So today, for agenda, what are we going to be talking about? First of all, we're going to be talking about what is patient-oriented research, what is patient engagement. I gave myself lots of time. Guiding principles. So giving you an overview of what some of the principles are. It's always important to understand what it is not. And then some of the core beliefs, why we should engage, levels of engagement. We'll do a quick overview, but we'll step one later on this subject. And then finally, we're going to have this really exciting funding announcement for everyone. So that's the teaser to keep you here, keep you going. So disclosures, because we're accredited now by the Canadian, the Royal Canadian Physicians and Surgeons Association, I need to make sure that I let you know that I'm employed here at the Georgian Fahey Center for Healthcare Innovation. So that's my disclosure. So first things first, it's interesting when I talk to health researchers, disappear when I talk. So you may have seen the previous, let's try to get that up again. When I talk to health researchers, one of the big, we're not going to get it to come up, but one of the biggest things we talk about, patient partners and health researchers, when we come together, one of the biggest things that we start learning is we have to be comfortable with being researcher, whether we identify as a healthcare policymaker or healthcare professional, or a patient, a caregiver, a member of the public, we all come together. When we come together, we all have our own political, social, cultural, experiential, and subjective knowledges. And so that can sometimes be a little messy and a little bit uncomfortable because we're going to disagree sometimes about certain things. But the most important thing is to lean into it. And what we're going to talk about today, we're going to give you an overview of key, but as we proceed, we're going to talk more about those situations, sometimes the challenges, sometimes the successes that go along with this, and how we can manage communication and conflict resolution. So I always encourage you to keep on going because every month we'll have really neat conversations around this. But today, the Georgian Fahey Center for Healthcare Innovation is part of a national initiative known as the Strategy for Patient-Oriented Research. And so the acronym is SPORE. And we want to know what is patient-oriented research, because a lot of times there's a lot of confusion about what this actually means. So it's seen as a continuum of research that engages patients as partners, that focuses on patient-identified priorities, that improves patient outcomes, It also includes, it's conducted by a multidisciplinary team in partnership with relevant stakeholders. That includes policymakers and healthcare professionals as well as patient partners and caregivers. And finally, it aims to apply the knowledge generated to improve healthcare systems and practices. Now, notice I've capitalized and underlined the "and," because that's where some of the confusion comes. A lot of times I may have health researchers say to me, you know what, I do patient-oriented research because my research works to improve patient outcomes. But when we talk about patient-oriented research, it also has to be engaging patients as partners in research decision-making. It has to be focusing on patient-identified outcomes. It has to be including that multidisciplinary team and looking to apply the knowledge to the healthcare system to improve the healthcare system and practice. So, for the strategy for patient-oriented research, defines patient engagement and health research as the meaningful and active involvement in patients in the governance of research. So when we say governance research, we actually mean patient partners at the highest level. So on steering committees, on operations, on the research team. We're also talking about patient partners, caregivers as part of the priority setting process of research. Patient and public partners also conducting the research. We've had patient and public partners and caregivers doing interviews and actually being full co-researchers. And then knowledge translation, very important. So at the end, how do we share the research findings with other patients and caregivers? It's important to include them in that conversation as well. Now, Involved's been around in the UK since 1997 around, and they define it as public involvement in research. And it's research that is carried out with or by members of the public rather than to, about, or for them. So that's a little bit more of a clear definition. And then for me, one of our audience members is in that picture. So for us, a lot of times the way that I try to describe it to people is having people, informal caregivers, communities with lived experience of a health issue, having a say in the research, the decision-making about the research process. So having a say in the research question, the design, the methodologies, the interpretation of the data, the translation of the knowledge. So all throughout that process, having a say in research decision-making. And so some of the guiding principles include inclusiveness. So this is actually from a strategy for patient-oriented research, patient engagement framework that you may have noticed before. And so inclusiveness, what we mean by that is that we're integrating diverse patient and public perspectives and research that reflects diverse contributions. A lot of times what we hear, and we're trying to get away from it, is researchers, oh, sorry, I've got, there we go, let's go back to inclusive. So a lot of times we need to make sure that we're not just taking one person with experience, putting them on a research team. We need to ask ourselves questions like, who experiences this health issue differently? So it could be as simple as men and women, different experience a condition differently. Who has different access to healthcare systems? So we know geographically, there may be differences between rural and remote communities and urban communities. But we also want to think about systemic barriers around racism, colonialism, sexism, homophobia, transphobia, ableism, sizeism, all of those pieces as well, because we want to make sure that we're including all of these different perspectives in the research decision-making process. And that might take a little bit more time, and it might mean that you need to use different types of participatory approaches in order to get those voices together, get those perspectives, but it's really important. We talk about support, and that means support for patient and public partners to be able to fully contribute. And so that means things like creating a safe environment. Perhaps people with lived experience around a certain condition don't feel so comfortable coming to a hospital setting or coming to an academic setting to meet together because perhaps there's been experiences of trauma in the past or just and it's just a feeling of power imbalance. And so maybe it's meeting people in the community instead. Also, a big thing of mine, and we're going to talk about this in later sessions, is anti-oppressive and trauma-informed perspective. So we want to make sure we understand this when we're engaging people as well. We want to also make sure that there's appropriate training, education, and compensation. So compensation for people's time, for people's contribution, for coming and joining, their insight. And we're going to talk about, in later sessions, we're going to actually talk about how to build a budget for patient and public engagement. We have a neat tool to introduce as well. Mutual respect and recognition. This is important. The research team members need to understand the true value of experiential knowledge as we come together and recognize it. Co-building. So this means public, patients, researchers, healthcare practitioners, health decision makers coming together at the very beginning to identify a problem and some of the gaps that may be occurring, to set priorities for research, and to collaboratively produce and implement solutions. Co-learning. This is an interesting part because a lot of times we talk about capacity building for patient and public partners. So patient and public partners learning more about the research process and so on. But there's also a lot of learning to be done with health researchers as well around how to meaningfully and authentically engage people with lived experience. Communication, conflict resolution, all of these pieces are really important as well. And then reciprocal relationships, understanding that it's about shared power and decision making, and that it's about transparency, honesty, and trust. Trust comes up a lot. This is an important part. It's about building a relationship, which takes time, and that means open communication, being reflexive, both researchers and patient partners, and understanding how to resolve conflicts. For me, I put the tree up as well. Again, the trauma-informed piece. We also have to think about resiliency, safety, empowerment, cultural competency, hope, recovery, all of these types of things. And we're going to talk about that further in some of our other sessions. What patient engagement is not. We need to understand what it is, but we also have to understand what it is not. It's not about people being recruited to a clinical trial or other research study to take part in the research. Remember, it's about decisions about the research process. It's not people completing a questionnaire or participating in a focus group as part of the research study. Remember, it's about the decisions. Science festivals that are open to the public with debates and discussion on research. These are great ways of informing people about your research, but to have true engagement, there has to be a two-way dialogue versus a one-way. We also open days at research centers where members of the public are invited to find out more. This is an awesome way, this is a great way of sharing your research findings. But again, we want the two-way. Same with raising awareness through media or dissemination to participants. We want that two-way where people with lived experience can actually inform decisions about the research process. So the core belief is that is patient public engagement, the involvement of people with lived experience. If we do it right, we'll help improve health outcomes and an enhanced healthcare system. We'll increase the quality, the appropriateness, the acceptability, the transparency, and relevance of research. We'll also ensure that health research actually addresses issues of importance to people with lived experience of a health. But we also need to be assured, and we'll talk about this in more detail at another time, but there are times people don't identify as patients. And there's a number of reasons why. So people who are unable to access a healthcare system, like we were talking before, because of geography or systemic barriers, people living with mental health or substance use issues, or taking up the label of patient, may also be associated with stigma. And so we have to understand. And people who may refuse to engage or prematurely exit because of unresponsive or disrespectful care within the healthcare system. And also people living with disability who are differently abled may have felt like they've been continuously medicalized by the system and of course may not identify it as patients. So this is again where we always need to be asking ourselves, who experiences things differently? How are we going to make sure that all of these voices are being included? And it's beyond just words like patient, but rather how are we going to include all of these voices, those who may not be able to access? Why should I engage? Well, I think we're actually, we're going to move to, the best thing is maybe not for me to talk about it, but maybe some of our patient partners, our health researchers, our healthcare decision makers. We asked them about the importance of patient engagement and health research, and this is what they had to say. Look at it working, don't I? Oh.
Quickly became apparent to me that patient-public community engagement was absolutely key if we're going to address issues related to equity, issues related to disparities in health, and also in building healthy and productive communities.
Particularly in research, there's often a gap between what a researcher or a clinician would deem as valuable and what a patient thinks is valuable in either the questions we're asking or in their own clinical care. Ensuring that patient engagement happens early on helps us define questions that are valuable both to patients and researchers.
Well, I think that the research, especially in the healthcare system, patient voice should be heard and should be engaged in the research. This is something that I think it should be come as a priority. Patients should be identifying their questions. They should have a right to know what the research is going on. And they should have a right to understand the methodology as well as the data interpretations.
Patient-public engagement is really critical to clinical trials, I think, because without knowing, without engaging the patients or without engaging the public, when you're coming up with appropriate outcomes or research questions and things like that, you might have a research question that you think is perfect and a solution for a problem that you think will work. And if you don't engage the people who are living, say, a particular condition, you might try and you spend lots of money on developing a solution that won't work in a real world sense because you haven't tested it in a laboratory or you've tested it in a very controlled trial and you try to translate that to real life, it doesn't work. So that's where talking to patients or the public can help you avoid those situations.
I think patient public engagement is important because as patients we have a different perspective, we look at different cultures, different and people with experience we can have, we can bring a different perspective to this solution and be able to work with researchers to collaborate and provide our input on how even with certain chronic conditions can impact our day-to-day lives and be able to incorporate that daily routine. And by working with researchers, they can understand and be able to come up with solutions that can incorporate daily lives without impacting our team. Because that way, there's a better chance for patients to adhere to that care plan. Because that it is not interrupted, they will not affect their outcomes. So when we're talking about patient engagement, we're talking about partnership, and that means around people actually having a say around research decisions, versus with a participant, it's you're being actively involved in the research itself, but there is quite a difference between those two.
So that's some of our patient partners and our health researchers that work here who work in and around patient and public engagement. And you got to see me again. Sorry. Can't escape it. Okay, let's. Oh. Sorry, folks. We're going to move on to. There. Why should I engage? So first of all, we can engage people with lived experience around how to identify a research priority that matters most to people living with a health condition being researched. A good example of this, and something that resonates with me because I read about it, is around rheumatoid arthritis. I'm a person who's lived with rheumatoid arthritis since I was a little kid, and so there was this research study where researchers were convinced that people with lived experience, their number one priority was around pain management. And so they went and engaged a diverse group of people with lived experience around rheumatoid arthritis. And what they found out in a priority setting exercise was, in fact, fatigue was the number one issue that people were currently feeling like they needed more research and more help and support in, simply because they were thinking about, how do I get up in the morning? How do I get on with my life? How do I look after grandchildren or get my kids to school? So in engaging, they actually redesigned the entire research process because they realized they were looking at something that patient partners definitely didn't see as their number one priority. Another way, you can engage people with lived experience around shaping and clarifying the research question, so it actually reflects the needs and concerns of patients and informal caregivers. An example of this was in a mental health study. People with lived experience helped craft not only the study name and the materials in order to reduce the stigma that's associated with mental health, but they also reframed the entire question and the goal of the research study so that it was more about towards emotional well-being rather than away from mental health challenges. And what happened was the benefit of having this perspective early on meant that they recruited far more participants because community felt a lot, this resonated more with their experience than had it been the original research question and goal. To help ensure that the methods that are being proposed in your study are appropriate, are sensitive, are acceptable to the real world context of patients and informal caregivers where they live, work, and play. So a few different examples, one of them being the chronic pain study. They had proposed to do this very lengthy phone survey with people living with chronic pain. And when they started to engage patient partners around it, right away, they said, there is no way that somebody's going to do this lengthy phone survey. This isn't the best way to reach people. And so patient partners actually helped redesign the survey tool so that it was a self-reported, self-paced tool instead. And what happened was they ended up getting far more participants in the end as well. Also, there was a large pragmatic study around chronic pain again, where patient partners actually observed how patient participants were going through the study process. They got their consent and they went and they observed the process. And then they gave some ideas around how patient-centered that study design actually was. And then the researchers went back and redesigned it. And then it was actually far more recruitment. Things were working way better afterwards. There's so many different examples of this as well. To help ensure research uses outcomes that actually have true meaning to the lives of patients and informal caregivers and communities. It's amazing how many times we talk about patient-reported outcome measures, but they haven't been designed with patients. And so how many times I know with me, I've had a loved one before say, well, I had surgery and I answered this long survey afterwards, and they didn't ask the question that I really wanted them to ask about. And I'd love to know how many other people like me are experiencing this. And this is an actual outcome measure that's important to me. So it's really important to think about how to engage people around what outcome measures are important. So there's a study actually about prescription drugs for people who had survived a stroke. And so they engaged people who had stroke survivors serving, and they were patient partners on the research team. And they actually ended up identifying home time, or the number of days when a patient is living at home and not hospitalized or in another institute, as a really important outcome that should be measured. And so this input actually meant that they ended up putting an outcome measure that they hadn't previously thought about, and that it helped direct the study in a way as well towards something that actually matters to people with lived experience. Language and content. This is a really important one. Patients and public partners can help ensure that language and content of the information that's being provided to participants in studies is appropriate and accessible. In a chronic pain study, again, there seems to be a lot of chronic pain studies, the informed consent process was actually co-developed with patient partners to make it understandable to study participants. And this involvement helped improve the recruitment because potential participants actually felt that they were more informed and they felt more comfortable with the process. Again, increasing participation is one of the ones that we always see. Recently there was a pediatric surgery study where parent partners shared that were they to be approached to participate in a study, they feel more comfortable if the person discussing the risks and benefits, not only of the surgery, but actual involvement in the study was a surgeon. And so they changed this around because I think it was a research assistant before who was asking whether they wanted to be involved. And what happens, the adjustment to that protocol meant that more people were feeling comfortable in participating. To help co-develop ways to share your research findings with other patients, caregivers, families, and communities. A neat one, there's a large pragmatic study around pain and physical therapists worked with patient partners to co-develop a continuing education program that would be used afterwards from the recommendations of the initial study. It would be an important dissemination tool afterwards. And patient partners contributed to this continuing education program by providing feedback on things like what kind of therapy and communication techniques they'd like to would be more or less likely to be effective during an acute pain episode. So they're able to give some insight in that regard. To identify a wider set of research topics. This happens a lot. So a lot of times you get people together to talk about one specific issue, maybe it's a chronic health condition. And what happens is people with lived experience might bring up other pieces of the puzzle, right? Whether it's things like food insecurity or mental health or different aspects that are related to the research. And a lot of times researchers might say, well, this falls outside of the scope of what we're looking at. But it's really important to still take note of these questions that people with lived experience really want answered because they're potential research questions for later on, but also when you're publishing, putting in the discussion, these are other important areas that we need to take a look at as well. So that feedback loop, communicating with patient partners that yes, we're hearing what you're saying as well, and that it could set off a new research area. Also, people with lived experience can help interpret research findings from the perspective of people with lived experience. That happens a lot of times. People are like, oh, they can't interpret all of these things. But we've seen time and time again, where patient partners bring a unique insight, some of the data, even theming some of the information that comes out of a project from that perspective as well. So it's really good. Ensuring that, and of course the democratic piece, ensuring that research actually reflects the concerns, the interests, the values of the public, that money and resources are being used efficiently. This is an important one. Now, sometimes when you talk about patient-public engagement, you may have heard that there's levels of engagement. And we're have a whole session on levels later on, but we're gonna briefly touch on it. This is what it kind of looks like. It's a spectrum from the lower level of consultation all the way to the patient-public directive. And the spectrum is actually from the International Association of Public Participation, otherwise known as IAP2. And so at the consultation level, when somebody says I'm engaging at the consultation level, what that means, it's the lower end of the spectrum. It's about obtaining feedback and input on research decisions. Researchers still most likely maintain the majority of the decision-making power. Some of the participatory approaches, now when I say advisory groups, a lot of times what we see with the patient and public advisory groups is they start out at the consultation level and they gradually move towards the co-development and collaborative aspect as the research process goes on. Sometimes even the patient directed where they take on a chunk of the research process. So it's an interesting thing that it can fall on all of those spectrums. Now, when I talk about focus groups, interviews, public and town halls, comment forms, and surveys, remember when I'm talking about this, I mean around a research decision and not as part of the research study. So it's always important to just think about that. So say, for example, you want to engage people with lived experience around outcome measures, and maybe you want to do more of a focus group style, you're still informing part of the research process. At the collaborative level, we're talking about actively partnering together. We're talking about shared decision making. And some of the examples, of course, are having patient and public advisors, sitting on a research team, having equal say in a research decision. A little note about having people with lived experience on your research team is you still have to understand and utilize different participatory approaches to ensure that everyone has an equal say around the table and that you have a consensus approach to agreeing on a research decision. A lot of times I might hear something like, we have, from health researchers, we have patient and public partners on our research team. They don't say much and we all agree on the same things. Then there might be an issue because and then we start digging, and so we talk about have we made sure that we've had a safety conversation so that everybody's feeling comfortable? Have we put in place a participatory approach to run our meetings in a way that ensures everyone at the table has the opportunity to express their feelings? How do we resolve conflicts, and how do we make a decision that's shared? So, and there are a lot of times research teams, when we get together, we don't even think about those processes, but it's really important, especially if you're bringing patients and,
Question.
yeah.
I was just wondering, so you're engaging people to be part of your research team. How do you know that that individual is going to be representative of the larger group and they're not necessarily have their own agenda that may be a little bit different than a larger group of people that maybe aren't participating as much?
Right. So anyone who didn't hear, I'm sure you probably heard, so how do we make sure representation on a team? A lot of times I recommend more than one patient partner to begin with to try to get more than one voice there. We have some tools too that we can get that talk about when you are starting to engage people, how to have that conversation around how do you feel about different opinions coming to the table? How do you feel about, have you had experience around this as far as representation and so on? So there's some ways of figuring out before everybody gets together that it's going to be the right fit. But I always recommend having more than one. I try to get 3, 4, like try to get the table, because a lot of times there's more than one researcher at the table and then you get this kind of off balance. So it's good to try to get some different perspectives at the table, but also having that conversation at the very beginning around how we're going to communicate, how we're going to make sure we make decisions. Carly?
And just to add in, I work with Carolyn on all this, so you often talk to people about chatting with folks before you start this process. So not like an interview process, but a way of ensuring that the person is the right fit for the group. And so it's not just that you're grabbing everyone that wants to be involved, but you're actually grabbing folks that, you know, can meaningfully participate. And usually in those early meetings, you would get a sense of if somebody just not the right fit, right?
Right. Definitely. And one of the other aspects of it too is that patient and public engagement isn't necessarily just about having people with lived experience on a research team. So if you think about you want to engage youth and you want to know what outcome measures are important to them to include in the research study, youth may not want to sit around a table talking to researchers. You may have to choose a different participatory approach to engage them around that conversation. So that means moving outside the research setting a bit, but say giving a bunch of youth cameras to go, to go around and take pictures of outcome measures that mean the most to them that you then integrate into the study design and protocol. So it's meeting people where they're at as well, right? So just because someone may not be able to contribute in the research team circle, trying to find other ways to engage them around a decision where they're at. And that goes for a lot of different things. If you want to engage people living with substance use, like you're going to have to find different ways of engaging them, and you can still get an amazing amount of rich, informed decision making that way as well. And then patient and public directed. This actually means patient and communities and public actively control, direct, and manage the research project. All the decision-making power with regards to the research process is made by patients and public in the community. The researcher's role is typically just giving advice, guidance, training, providing support, or actually conducting the research, but under the direction of the community or patient partners. And the one thing is, a lot of people are like, oh my goodness, that can't be done. But we know for sure, especially in Indigenous research, if we think of OCAP principles, it is ownership and control. It is people with lived communities actually directing the research process. So it's done, and it's wonderful. Oh, I was just going to show you guys. So if you're ever thinking, I want to engage, and I'm thinking about this level, and I'm at this part of my research process, we do have a neat little tool on our CHI website, which is chimb.ca, and it's this little mapping. So we process mapped. And you can look at the phase or stage. Say you're at the research design phase, and then say you want to engage people with lived experience at the collaborate level. You can actually look at different participatory approaches, and then it gives you this whole little synopsis about what participatory design is, how it can be used, gives you some notes, and then it actually gives you some little additional resources that you can investigate further. So it has some suggestions. So it's a neat little tool that you can use. Leanne?
Do you have any participatory approaches that would be better through a teleconference call, not in person?
That's a good one.
And no visual aids.
And no visual. Oh, so just pure teleconference.
Yeah.
That's a good one. I'm trying to think of one.
So it's people from other part, like national or provincial.
Yeah,
everyone's on the call. And what level, like, is it in research?
So it's not specific to research, it's more health systems based. Because it's like a health project, but it's around discussing interventions for childhood immunization, how to improve rates.
And are they coming up with interventions to start? So I'm just thinking, is there ways that you could do something ahead of time, like a pre-survey or something that helps bring up the top number of ones for discuss? So say you ask people which interventions, they all give their ideas and pull out the top 3, which then get discussed at the full conference, like doing some of the pre-work.
Yeah, they have had an in-person meeting, so there is a list of interventions, and I'm not even clear on exactly what the overall goal is because it's to find like one intervention for that area. I'm not sure, but I'm trying to think of like a facility technique that would work on the phone.
Yeah, because you want to hear everyone's voice.
Yeah, and it's hard when there's no like WebEx or something, or online tools sometimes have chats, or you can visually see things, but that's not happening in this case.
I can set up a mini chat through email where people that don't feel comfortable speaking or aren't able to just make it clear, like email me questions as we go along.
Yeah.
So you, like if you have 2 people, maybe have one person manage some sort of question.
Sure.
Yeah. Carly answered her question.
I only can answer because Carolyn's talking.
Yeah, that's it. But those are great questions that we continuously, and we want to add to that mapping tool. So when we discover new ones, like how do we engage via teleconference and what type of participatory approaches can we use, it'd be great to add some of those ones in as well as we continue to learn about this process. And especially online as well, there's so many different things like Facebook groups and ways of engaging.
Well, and just in Manitoba as a whole, with our geography being as vast as it is, and with telehealth being as vast as it is, that's definitely an area for us to think about.
Yeah,
What works.
And what doesn't work, especially when we do broadband with and certain regions that don't even have. Yeah, how do we?
Because interestingly, in the group work that I've done with patient partners in our pre-talks, when we were figuring out who wanted to be involved in the group, we actually did have a couple people say, I'm not particularly interested in being involved in a group that's just via telephone. I would like to come and see people in person, and that worked out because we're all in the same city, but for the patient partners, that was actually really important.
Yeah. And this actually goes in really well because before you ever even start getting into what approach should I use and so on, it's first good to have an internal assessment, and we're going to get into this in more detail in our next session in October. But you first want to have an internal assessment, so looking at where the research team believes that engagement, whether it will improve the outcomes, what is the real potential, and this has to be an open and honest conversation, what the real potential is for patients to influence decision-making within the research process, what's the likelihood that people with lived experience that their research is actually going to be fully considered, and then what resources are available. But you also have to do an external. Okay, we're having an external one as well, which means you have to think about, you have to talk to people with lived experience before you can make this decision. So think about the previous history of engagement that's happened. So there are communities, there are people with lived experience who have not had good experience with engagement. So you need to be cognizant of that and making sure that what people prefer and how people prefer to be engaged is at the forefront. You have to think about what inequities exist. That's what we were talking about before. To make sure that we include all these voices. Talking to people about what their values and expectations would be around it, getting involved in these. And what level people do expect to. Because sometimes there's a difference, right? Sometimes internally, researchers are like, yeah, I'm at the consultation level. Sorry. And then you talk to people with lived experience and they said, actually, no, we want full collaboration or nothing. So you have to understand where people are at and then how people would prefer to engage, like Carly was saying. Now, to end everything before we make the announcement, I thought the best people, again, are our health researchers, our patient partners, and decision makers to give us kind of a little look at aspirations around patient and public engagement. So we're going to show one more video, much more entertaining.
Escape.
There's gotta be a direct link between,
Oh, okay. On the screen.
You can escape the slideshow.
Escape. There, are you? So it is this the video? Oh, it's still on. I think something wrong with the.
Well, Trish works on that. Can I ask you to clarify one, Carolyn?
Yes.
Because, so this is the thing that comes up in almost every consult we do with health researchers. And it's that point between having folks that are engaged in your research, but they are not also the participants of the research. And it often comes up with anyone that works in research with rare disease groups. So they'll say, you know, sure, I would love to have people involved in my research, but there's only 18 people in the province that actually have this condition, and they have to be my participants as well. And I'm never fully sure the advice to give on that. And so my question is whether or not there are situations that a person could be a participant as well as engaged in the research, or whether or not that is just too much overlap.
Definitely, and this one has come up in a few, yeah, definitely around the rare conditions. I think it's important. I think there has been some understanding that this can happen and that they can be both, but there just has to be very clear understanding of what you share as a partner. So if you critique a researcher or a healthcare clinician and you don't agree with them and so on, that's not going to impact your care. So those things have to be really, really clearly defined. We see this question come up as well, because more and more we want to research the patient engagement itself. So we get this double where patient partners are informing the research process, but we're also using the way in which patient partners are being engaged and data and to write about, so they become participants at a different level. So there's a consent process to use that data to research the patient engagement process while simultaneously engaging patient partners in the research decision. I think though that, I think the argument can be made, and I think I've seen some examples now around rare conditions where they both helped inform the research process as they were participants. And sometimes, I mean, you get that perspective because they are participants, they can really give you some understanding around the process and the design, whether it works and so on, from that perspective as well.
And so that's really helpful. So I try to steer people away from it for those exact, like just to say it's a little bit grayer, it's a little bit trickier, but it can be done as long as the boundaries are very clear.
Yeah, it can be done. And understanding where REB comes in as participants, and then as partners, CIHR I know is coming down with an ethics and engagement report, but a lot of times, so if they're patient partners on a research team, REB may not be included. But what I love to do, and what's always advised, is if you have patient partners as co-researchers, I always still put into REB around the research that we are going to make sure that patient co-researchers are well supported. Say if they're conducting research with their own peers, so people who have gone through the same process and something happens where they get triggered, making sure that you have a list of supports available in case that happens. So understanding that you still need to protect your co-researcher, your partner. Oh, Trisha's magic, and she got our film here. So here, we might not see the video today. Maybe we should go on to the funding announcement. I really wanted to use it. Maybe we'll see if we can send you the video as part of your online survey later on. So the big announcement, yay! So our third round of our funding award has launched right now. So this is a really exciting opportunity. This funding award was established to support and facilitate Manitoban researchers, researchers, students, and community organizations who are doing research to actively involve and engage people with lived experience, communities, caregivers at the early phases of the research process. So what we kept hearing from both researchers and patient partners across Manitoba was that engaging patient partners at the research priority setting, the research design, and the grant development phases of the research process, it was really difficult because they didn't have any resources to compensate patient partners. They didn't have any kind of in-kind supports as well. So this great funding award will enable you, there's 10 awards, it's $2,000, and it's open to all Manitoba researchers, students, and community organizations who are doing research. And this is going to help you kind of engage at the early phases and stages of the research process. So I'm just going to make sure that, sorry, there we go. So some of the eligibility requirements include that you are in Manitoba, that you have not yet applied for or received grant funding for this particular research project. Because if that's the case, you've probably made a lot of the research decisions already, and so you're not going to be able to actively involve them at the very beginning. That you're committed to engagement of patients and publics with the intention of applying for a larger grant from what's been decided upon in the engagement. And people who have previously been unsuccessful are encouraged to submit a revised application as well. We always welcome. $2,000, 10 awards. Some of the things that we want to make sure is you get a free consult with us. So right after the award, we'll contact you. We'll also help you just develop your key strategy so we get you on the right track, because we want to make sure that the funding is spent within the first year. And some of the things that applicants will be, some of the criteria that you'll be judged on is the type of participatory approach that you're proposing to use, the feasibility of the engagement that you're proposing, the willingness to adapt the research project depending on what people with lived experience say, the level of engagement that you're proposing, and then the inclusiveness of the participatory approach and methods being used as well. And award winners will be invited to come to reception and talk about their presentation. We'll also have a little bit of just a little brief report that we'll ask so we can find out more about what you're doing, and then also participating in an evaluation, because we want to know if these awards are helping or what kind of supports that you might need in addition. So just learning more about that. So I encourage everyone to apply. And definitely there's always, you can contact me. Oh, but of course, you can always contact me. There we go. Phone, email, Twitter, tweet at me if you want. And I'll be sure to chat with you further about that. And same with the Lunchtime Learning. If you want more information, always feel free to contact us. Our next Lunchtime Learning, I believe, is October 24th. And it's going to be talking about how to do the internal and external assessment to start building our patient and public engagement strategies. So I hope to see everyone there. Thank you so much. Do we have any questions? As I motor through. Jennifer.
Quickly, have you found a way to, I guess, keep the conversation even between people who may be calling remotely and those who be in the room, so that you don't forget that there's somebody on the line?
Yeah, definitely. That's where you can choose different approaches that ensure that each person has a say around each when you're having conversation. There's also ways of doing it on that people can contribute conversation online simultaneously while people are in the room. We have done research team meetings where we've had patient partners coming in via video chat and just making sure that everyone has an equal say. But there's definitely a lot of approaches that you can use that make sure that you're taking the time to pause and include those people as well.
Yeah, sorry, one incorrect
over the other, I'd have to take a look and see, which, and it would all depend on what you're talking about as well. Were there any online questions? No? Okay, excellent. Thank you so much for joining us. Okay.